Hello, I'm Shoghig. I am the program advisor for Profan. I am a master's graduate in the public health, and I am a student right now for the Doctor of Public Health degree. And today I'm with Barbara, my colleague from Profan, and I'll let her introduce herself.
Hi, my name is Barbara. I'm a support agent and training trainer at Profan, and I'm also a drug user.
So if we can get the presentation, perfect. So the title of our presentation today is Addressing Opioid Overdoses, a peer-led national public health program for better response to drug-related harms in the Quebec opioid crisis. And these are essentially all the authors of this abstract that we are presenting today. So next up is, yes. So before we start, we just wanted to greet you and tell you that it is with respect and gratitude that we gather today, and we are facilitating today from the island of Tiake, an unceded and unconceded territory also known as Montreal. We recognize that this place has always been a place of life, meeting, and exchange for First Nations, Inuit, and Metis people, particularly the Tehinian, Kehaka, and Omamawini Niawag nations. In a spirit of peace, justice, and reconciliation towards these peoples, we wish today and for generations to come to use our voice to highlight their cultures and knowledge, as well as to promote equity, human rights, and health. As such, we humbly invite you to take a moment to learn about and reflect on the past, present, and future presence of the Indigenous peoples on the territories in which you are currently located. Finally, we wish to acknowledge and pay tribute to the Aboriginal people and organizations present who are working daily for the well-being of their peoples and territories. And thank you. So next up is, what is Profan? Perfect. So Profan is the French acronym for Prevent and Reduce Overdoses, Training, and Access to Naloxone. It is a community-based peer-led training program initiative which uses a harm reduction approach developed to empower the peers in responding to opioid overdoses they are likely to witness in the context of the growing opioid crisis in the province of Quebec, since they are usually the first responders in the case of overdoses. So we have two trainings available at the moment at Profan, one for people who use drugs and the general population, and another one for the community sector. And both of these trainings are adapted for the Indigenous context. I'll let Barbara continue for this part.
Okay. Oh, I forgot to tell. My English is not very good, so I'll try, but probably I switched to French and my colleague Shoghig will translate. So sorry for that inconvenience. So the content of the training for people who use drug and the general population is a training about a day, 7 hours. And what we see, we identify the sign and symptoms of an opioid overdose. We do intervention in an overdose situation. We do a lot of simulation. We do also application of CPR technique and administration of naloxone, debunking myths, technical and legal consideration as the Good Samaritan law, for example. And for the training for the community sector staff, it's a bit longer, 7.5 hours. And we see a theoretical and practical notion of prevention, intervention in an overdose situation, administration of naloxone, and brief review of CPR. We see case studies addressing overdose risk prevention and intervention protocols for organization to implement. And also, which is important, post-overdoses intervention component aiming to promote the return to balance of the person who has witness of suffering an overdose. It's very important to take care of ourselves after those things.
Thanks, Barbara. So I will move on, and what we will present today is essentially how the program started, how it got developed, and where we're trying to be headed right now. So it started when, in 2014, actually, there was a heightened deaths from opioid overdoses, and Metadam, which is an association from peers for peers, created a half-day naloxone and first aid training program for peers to identify the risks and be able to act in case of an opioid overdose. as I said, they are the first responders usually. And for 3 years, we did that initiative. And then the Ministry of Health and Social Services in Quebec also decided to have a policy regarding the crisis, opioid crisis in Quebec, and published its first ever strategy to respond to the opioid crisis in Quebec. And that's when they mandated Metadam to have a more comprehensive program that would be delivered to the community sector, to the community workers, volunteers as well. And that's when the IDQ in French, which is the Association of Intervention Workers in Addictions of Quebec, also joined efforts with the Metadam to be able to develop a more comprehensive version of this program, which is the second type of which is the two that Barbara just explained. And then we're also trying right now to scale up our program to make the regions, because we have 18 different health regions and public health authorities in Quebec. We're trying to scale this up inside the 18 regions by making the regions autonomous and be able so that they can adapt the training to their contexts. Next, just a little bit of a, there we go. So Barbara, you can go ahead.
Okay. So at the beginning, as Shoghig talked about the organism Metadam, which was peer for peer, and that started with the fact that people were dying, and naloxone was just we just have access to naloxone in hospital, and so with that frustration, and we want to do something, so we did the pressure to create that first training, and which people je vais dire en français, les gens qui assistaient à cette première formation-là pouvaient avoir une carte pour aller chercher. C'était la seule façon d'aller chercher de la naloxone à la pharmacie au début, c'était de suivre cette formation-là au début.
Yeah, initially, the only way that people could actually go get naloxone from a pharmacy was to go and get this training. That's how it worked. You could have only get it that way or in hospitals.
At the beginning. Yeah. So the objective were at the beginning, demonstrate that the administration of naloxone by peer is effective in saving lives, and also demonstrate the feasibility and the credibility of this initiative in order to sustain it. So peer were involved at every stage of its development and implementation.
Awesome. And next. So there were 3 organizations which were involved. Obviously, Metadam was the lead in this project, but there was also the Center for Research and Assistance for Narcomans and the Public Health Regional Authority of Montreal, which was very aware of the problem that was going on in Montreal and decided to help out with the creation of the program. And then here we have 2 pictures of the very, very beginning of the program. And what you see here in the second picture is the first kit that ever existed in Quebec, the first naloxone kit, which was actually created by Metadam. So that's something that we are very proud of and that we are very happy we were part of. And just to mention, we can get naloxone kits everywhere in Montreal right now in pharmacies whenever we want from the general population. There we go. So Profan 2.0, essentially, I don't see it. Yeah. So the mandate that was given by the Ministry of Health to Profan now, which was Metadam and the Association of Intervention Workers together, was to first of all train the community sector workers, peer groups, and trainers for all of Quebec, develop awareness campaigns and information tools to prevent opioid overdoses, and to participate in working and consultation bodies for the prevention of opioid overdoses. And this is where it got a bit complex for the Association Metadam, because it was a bit as if the role of peers was questioned, and they had to demonstrate that they were still relevant and prove their ability to manage the program, because they became the main managers of the program, and that they had to defend the added value of involving peers in all of the aspects of the program. But what we saw as we went on through the program implementation is that peers had taken on roles of leadership in design, financing, governance, implementation, and information sharing when it came to research results very actively. And they were also active more in a collaborative manner in participative research with our research team, the Gloss Research Central with Dr. Michel Perreault, which was more the development of evaluation plans, the evaluation itself, and the data analysis. And this is one of the pictures of how our program our trainings are given. We have here at the left one of our best peer workers that showing how to simulating a CPR. Then we have a training for the community sector, and then we have a simulation of training for the peers at the right side, where they're learning how to do CPR and administer naloxone on actual, fake bodies. Okay, perfect. I'll let Barbara continue for this part.
Okay. So there's a few trainings in Quebec for naloxone, but the specificity of Profan, which we call the Profan effect, is the fact that the training is always given by two persons, a person with experience, knowledge transfer via a peer, and the person with clinical knowledge transfer via an intervention worker. And they both are equal giving the training, and that created an effect of destigmatization. And it's very the people it's the fact that we have it's difficult in English, sorry, le fait que on va donner des exemples concrets, à la fois des intervenants qui travaillent, on a des intervenants qui travaillent dans des sites d'injection supervisés, des travailleurs de rue qui vont livrer leur expérience, et des pairs, des personnes qui utilisent ou ont utilisé, qui vont livrer des expériences. Ça va donner une formation plus vivante.
Yeah, so what happened is that with the Profan effect, we actually have intervention workers and the peers who give very concrete, real life examples from their own experiences because the intervention workers have worked in supervision injection sites, and the peers have had a lot of experience in with drug use. So they use their knowledges together and they put them together, and it gives a new kind of knowledge transfer that isn't just technical and theoretical. Yeah, and actually, I'm just going to add here we've put peer and intervention worker, but at Profan we have actually gotten out of this box of calling them peers and intervention workers. We don't call them that in any of our posts, or as you said, as Barbara said, she's a trainer and support agent, and we use more the words experiential knowledge, clinical knowledge, because that's where we see the value, and we want everyone to be equal inside the program. That was just a parenthesis. There we go. Perfect. And what we can see about the Profan effect is from the beginning until now, about 20% of participants have always remarked the fact that there was a peer that was sharing concrete examples. And what we have comments here, which was relevant training. Having a peer training is an important asset and brings real and concrete examples that help to better understand the reality of opioid users. And then we have, wow, it was the first time I had training given by a person living with the problem. And it's super informative. For once, we didn't just have the vision of the intervention workers. Congratulations, the name of the peer. You are inspiring and proof of success for all. And for the peers as well, it had an effect when they had a peer that was a trainer. And 25%, as it was shown in a study by Dr. Perreault in 2021, 25% reported that taking part in a Profan and being trained by peers like themselves instilled hope in them for their futures and inspired them to go back in school or become support workers to help others in trouble and distress or bring change to their lives. And I'll let Barbara use some examples from her life to describe this.
Yeah. En français. Donc, oui, c'est ça. J'ai consommé pendant près de 30 ans tous les jours de l'héroïne. Et pour moi, ça n'a jamais été une consommation récréative ou heureuse. Pour moi, c'est synonyme de souffrance, de perte. Je ne me considère pas comme une bonne mère, comme une bonne enfant, comme une bonne amoureuse. J'ai perdu mon travail. J'étais professeure de philosophie. Pour moi, c'est une série d'échecs.
So for Barbara, she had been using opioids, specifically heroin, for 30 years, and it wasn't just a recreative use for her. It was a lot of suffering. It was a lot of loss. She considered herself a bad parent, a bad child, and didn't have a lot of confidence in her health and herself. And yeah, I'll let her continue.
C'est ça, donc ça faisait près de... J'avais cessé de travailler, j'étais professeure de philosophie avant, mais là, je travaillais plus, puis j'étais vraiment toute seule chez moi à consommer et je voyais personne, j'étais très isolée. Pour moi, j'avais 55 ans, j'allais finir comme ça quand Profane m'a engagée.
Okay, so she was a philosophy teacher. She lost her job and she was always alone, using alone. And she was 55. And then that's when Profan actually mobilized her and told her, come and work with us.
Oui, je pouvais pas refuser, comme j'étais prof et héroïnomane, donner des formations pour réduire les surdoses d'opioïdes. C'était fait sur mesure pour moi, donc j'ai accepté. Et ce qui s'est passé, c'est que à Profane, on nous accepte même si on consomme. J'ai plein de collègues qui consomment tous les jours, les fins de semaine, le soir. Tant que le travail est fait, bien entendu, on nous accepte en consommation.
Actually, she had to accept because since she was a philosophy teacher and heroin, she wanted to help in a way that would use her skills. And she joined, and it was very nice for her because everyone around her, the peers, are actually, it's very accepted in Profan to use drugs. We're aware that people use drugs, that they have used drugs and have stopped, or they still use, or they have stopped using them. And there's the mix of everyone, and it's accepted by the intervention workers, by the other workers, and by the peers.
Et c'est ça, moi, je me jugeais beaucoup, je me stigmatisais énormément et mes collègues avaient pas le même regard sur moi. Ils m'acceptaient comme j'étais, ils trouvaient que j'étais une bonne personne, que j'avais des choses à apporter, que mon expérience négative pouvait se transformer en positive expérience pour améliorer les protocoles d'intervention de surdose. Donc, moi, ce que je considérais comme négatif est devenu positif dans le regard de mes collègues.
Yeah, so what she's saying here is that even though she would judge herself and she would have a very negative outlook on herself, the others around her would see her experience and her skills as a plus, as a positive feedback to be able to develop protocols, intervention protocols, to use her experiences to develop other tools in the program, and even use her skills in the trainings that were given. And for her, it was a shift from negative to positive because she was seeing herself as negative, but the others as positive inside Profan.
Et c'est ce changement-là, tranquillement, le fait que mes collègues m'appréciaient, moi, je m'appréciais pas, que tranquillement, le regard sur moi a changé, puis ça a fait que au bout de 9 mois que je travaillais, où je consommais tous les jours, tout d'un coup, c'est comme un miracle, j'ai arrêté de consommer. Ça fait aujourd'hui 9 mois que j'ai arrêté. Et c'est un miracle parce que j'ai essayé tellement de fois avant, puis ça s'est fait tellement facilement que la seule explication, c'est vraiment le regard de mes collègues qui a transformé mon propre regard sur moi, puis ma vie a commencé à avoir de la valeur.
Yeah, so she's saying something very important here, which is it is the outlook of herself that changed because of this. And she was able to start seeing the positive in herself as well, and be able to use that and be positive. And then what a miracle happened for her, which is she stopped using drugs very easily, even though she was having a lot of trouble in the last years to be able to stop, and she had tried everything, and for this came very easy to her in Profan. And as she said, it was a miracle for her. And this was only she was only able to do that because she was able to look to herself in a better way because of what Profan actually stands for and tries to give to also the participants. And that is also what the participants feel like from what we have seen in different comments in our participant reviews.
Yeah, t'as bien résumé. That's it.
So I'll move on with this, and what we have next is more the impact, and it joins back to what Barbara was saying, which is it's the impact reported by participants. So it's an improved sense of control and feeling of competency to deal with potential overdoses and other emergency situations, heightened feeling of responsibility to help others, increased feelings of pride, confidence, and self-esteem, overcoming social stigma, renewed sense of hope, and changes in drug use behaviors.
Yeah, for the sur le changement de comportement, c'est très différent de voir des affiches, des campagnes de prévention sur une affiche sur un mur quand on est dans une salle d'attente. C'est très différent de voir, c'est écrit ne pas consommer tout seul, mais quand on est en formation puis qu'on a une personne qui nous raconte comment elle a failli mourir parce qu'elle était seule, ça a beaucoup plus d'impact. C'est ce qui fait qu'on retient plus la matière qui nous est transmise.
Yeah, and another thing that she's adding to the whole thing is that when you see campaign promotion posters on the walls in your doctor's office or other places, it's not the same as when during the training there's someone who is concretely giving the example. For example, someone who is using alone, don't use alone on a poster, and someone who's saying, oh, someone died, as someone was almost dying because they were using alone. So it's a very concrete examples that help people shift into really that prevention mode with another type of outlook of what it means. So this is a bit outside of the scope of our abstract or of our presentation, but we just wanted to mention that there is systematic monitoring and evaluation of our program, which is done by the Douglas Research Center by our research team of Dr. Michel Perreault. Here we have put three the last three publications. There are more, and we have done also reports and other scientific communications for Profan. So if you are ever interested, you can go check it out for Profan. Okay, perfect. So now about implementation. As I said, Quebec is actually the biggest province by land in Canada. It contains 8.7 million people, and you can already realize that we are a small team. Actually, we're 10 to 15 people, maybe 20 maximum, and it is actually very hard to be able to complete the mandate that we have in the entire region and the entire province of Quebec in the 18 regions, and because the demand is a lot higher than the supply that we have. So we have, and our numbers are actually pretty good when we compare to what we have as a team. And from the start of the program until now, we have nearly 180 training courses that we have offered. There was 16 of the 18 health regions that were covered by the training. We have trained nearly 600 organizations and 2,500 people. And almost in 90% of these 2,500 people said that they were satisfied and comfortable in acting in an overdose situation. Okay, and as Dr. Perreault and Al in 2023 showed, they showed that there was facilitators and barriers to the implementation of the program. Some of the facilitators were that there was a presence of an active peer network involved in harm reduction in the region. So when there was a community organization which was very active in that region that was peer led, that's what helped us a lot in organizing the trainings and having a lot of peers come to the trainings. And the collaboration among community and public health sectors, because each region has their own public health authority. When the public health authority is able to be very collaborative with the community sector in that region, we have seen that it has been very facilitating to organize the trainings. Also, the awareness of the opioid situation by stakeholders. For example, if some of the stakeholders are aware of the problem inside their region and they're not negating it, or they sometimes they reach out to us because they know there is that problem in their region. So that was a facilitator. And the perceived appropriateness and acceptability of the training by stakeholders. We are a very credible program inside of Quebec. And because of what we just mentioned earlier, everything that has come, the process that we have used, we are actually a very credible program in Quebec. So when we don't have the facilitators, we have a lot of barriers as well, such as the two of the regions that we haven't visited is because of geographical isolation. There's also sometimes existing offer of similar services in some regions, and that's actually good because that means they've become autonomous in training their community sector and their peers inside the region. Difficulty reaching the peer community, and I'm sure that's a problem that's in a lot of harm reduction organizations. And also there's a lot of stigma and towards the peer community. So and unwillingness of stakeholders to address the opioid problem. Sometimes community organizations, when we would organize trainings, would say, "Oh, we don't have that kind of problem here. That's not a reality for us." When we know for a fact that there have been deaths and there has been an increased risk inside that region. And of course, the biggest problem is the lack of funding stability, because tomorrow the government could decide that they want to be disengaged and that they don't want to do anything with the program anymore, and we can stop working right then and there.
Just to say, in the small area, everybody knows everybody, so they won't come to a peer won't come to training because they're afraid that somebody's going to talk, "Oh, you're a drug user." There's a lot of people that don't tell they use. They don't want. Sometimes people said, "Oh, we won't go to the pharmacy to take naloxone because it's the brother of my sister or whatever." And I know that people, so it's very, ça empire la situation. Ils ont un problème puis ils en parlent, donc c'est très difficile de venir en aide.
It worsens the situation, yeah. So there are some challenges that I'll cover this. And I'll cover this a bit very fast, which is the pandemic context, which everyone was dealing with, the state disengagement, exacerbated overdoses, instabilities in the media, and multiple actions and initiatives in the province of Quebec, which lack concertation and consolidation and aren't very cohesive together. And specific challenges that we have faced in the implementation is that since we're a small team, it is hard for us to develop and we actually develop, implement, and deploy at the same time. We develop tools while we are organizing trainings, while we are also inside the regions, moving around and trying to train people. So we have had also organizational, operational structure problems that we are now trying to solve, team building and staff retention, because there's a lot of movement in the community sector and especially in the harm reduction sector. Maintenance and evolution of governance, difficulties with data synthesis and analysis, because we collect a lot of data and we want to be able to use it well to make our program better. Knowledge transfer of expertise and know-how, because as we said, it's not only technical theoretical knowledge that we are sharing to people, it's really the experiential knowledges and the know-how when it comes to the actual prevention of overdoses. Emergency situations that are expanding and growing, and the integration of peers inside the team. And finally, we are trying to go towards a scale up, as I said in the beginning, towards a train-the-trainer model to be able to sustain the program and have each region be autonomous and adapt the program to their regions. And we have 2 pilots underway right now, but the government who had given us the mandate to do this has now decided that they don't want this to happen. So we are lacking funding. So we will see what will happen in this case. But we are sure that we will be able to do it. So thank you very much. And we are at the end of our presentation, and we have, I think, 2 minutes for questions. I don't think there are any. So so I think this is the end, and thank you for listening to us, and it was good being with you all. Bye.